team of cardiologists, cardiac surgeons, cardiovascular anesthetists, intensivists, and specialized caregivers who works tirelessly to ensure the patient receives compassionate care at every stage of their treatment. We at Billroth Hospital has successfully completed more than 50,000 cath lab procedures, 10,000 cardiothoracic surgeries. We are happy to start the day with a roundtable meeting with experts in the field to formulate guidelines and protocol in managing critical conditions like cardiogenic shock, acute pulmonary embolism, and cardiac arrest. Our goal is to build structured protocol, clear activation pathway, and synchronizing response system that functions without delay. With a great respect, I invite our chairpersons, Dr. B. Ramamurthy, Dr. A. Chakravarti, Dr. Veena, to the dais to start the proceedings. It is a proud moment for all of us in Chennai to have Dr. Kamlesh Anbalakan, Clinical Assistant Professor and Cardiac Intensivist of National Heart Center, Singapore, to guide us throughout. I also invite core group members for this round table, and we are sure that expertise will surely be mutually beneficial. I invite Dr. Shanmugasundaram sir, Dr. Ilayaraja, Dr. P. Vinod Kumar, Dr. Ramesh, Dr. Samuel, Dr. Mohan sir, Dr. Bharat Guru, Dr. M.K. Prashant, Dr. Elangovan, Dr. Lavanya, Dr. T. Parthasarathi, Dr. Amal Johnson, Dr. Jagannathan, and our consultant, emergency team, cath lab team, critical unit team, and cardiothoracic surgery team. Thank you for joining us today. I request Dr. Shanmugasundaram to initiate the proceedings.
Good afternoon, dear friends. It gives me immense pleasure to invite you all for this roundtable meeting. As the name implies, it is meant for mutual exchange of ideas and knowledge so that we tend to provide better care for the sickest people. We already are doing a good job in STEMI care and stroke care in our hospital. Time delay is averted. The procedure gets finished in time, and obviously the mortality is coming down and the duration of hospital stay is coming down. We thought me and the colleagues in the department thought that similar things should happen in the other areas, somebody coming with cardiogenic shock, somebody coming with acute pulmonary embolism, or someone who presents to ES emergency room with cardiac arrest and so on. It so happened that I could have an opportunity to meet Dr. Kamlesh Anbalakan when I went for a meeting. When I listened to him, I thought I should somehow bring him here for initiating our thoughts, like formulating a cardiogenic shock team, formulating a pulmonary embolism response team, and ECMO-assisted CPR in the emergency room itself. I thank Dr. Kamlesh for having come and grace the occasion. He's supposed to go to UK for some advanced training, but he could spare some time and join us. I once again welcome all the core group members. Kindly get things clarified with Dr. Kamlesh, because the advantage is he is not going to tell us what is there in the literature or in the books. He is going to share how hard he initiated the cardiogenic shock team or the shock team and the PERT, pulmonary embolism response team, in his place, National Heart Center in Singapore. So that is going to be a lively discussion among us. I request Dr. B. Ramamurthy, head of the department, to start the proceedings.
Good afternoon to all. At the outset, I want to thank our guest speaker, Dr. Kamlesh, for having come all the way from Singapore to share his vast experience and take part in the very healthy, interactive discussion which is to follow, especially in a few cardiac emergencies like, as Triple S said, cardiogenic shock, pulmonary embolism, and eCPR, which we see in clinical practice very often. So as you all know, cardiogenic shock is a very challenging subset in cardiology. Why it is challenging? Because it has got a high mortality rate of almost 80%, which was 80% almost few decades ago. Now it has been brought down to 50% with the advent of all these recent advances in therapeutic management. But it still continues to be high, around 50%. And you know that cardiogenic shock is the commonest type of shock. Almost 2/3 of all the shock patients getting admitted in CCU it belongs to the cardiogenic shock type, which is then followed by other types of shock like hypovolemic, distributive shock, and those other things. But the commonest cause of cardiogenic shock is the STEMI, acute MI, which happens in almost about 5 to 10% of STEMI cases. And the cardiogenic shock is very common, is higher incidence in STEMI compared to NSTEMI. But however, when you compare the mortality, the patient coming with an NSTEMI with cardiogenic shock has got a higher mortality compared to STEMI with the cardiogenic shock. So this is one thing. And this cardiogenic shock is a complex syndrome. It is a dynamic process. That means the patient comes initially with something like a mild stage, but rapidly become very worse. That means the evolution progression can take place very rapidly in a particular patient within few hours, whereas in other patients it may go on for 24 hours. So it is a very dynamic process, and it needs a multidisciplinary approach, because it's not only going to involve the cardiologists, but also other specialists like cardiac surgeons, when we want to put a MCS device, and also anesthetists and the ICU specialists. So it is going to be a multidisciplinary approach, and integrated coordination is very, very essential among all these specialists to carry out the correct therapeutic strategy. So this is a thing. Then coming to this, why this cardiogenic shock, it's got a heterogeneous population. As I said earlier, at one end of the spectrum of cardiogenic shock, we have a patient coming with acute MI with isolated myocardial dysfunction. Whereas the other extreme, you will see a critically ill patient with a multi-organ dysfunction. So it has got a heterogeneous population, and we need to know all the hemodynamic profile in all these patients so that we we select the correct therapeutic strategy. So these are all some of the things which we should know before you start treating the cardiogenic patient. Then coming to that, you should know at least 2 types of classification in a cardiogenic patient, because that is why it's very important. It's very useful to select the correct strategy. The one is the SAI pyramid scale, which classifies into stage A, B, C, D, and E, depending on 3 factors, namely the physical findings, laboratory findings, and the hemodynamic profile. So the hemodynamic profile is very, very useful in cardiogenic patients, because if you want to do really effective management, one should have a very good knowledge of the hemodynamic profile in a given patient. Why it is very important? Because not only it helps in confirming the diagnosis of a cardiogenic shock, it is not only the hemodynamic profile is not only useful to confirm the diagnosis of cardiogenic shock, it also helps to differentiate the various types of shocks. And also, even in cardiogenic shock, there are different subtypes. So you will know which subtype of cardiogenic shock this particular patient belongs to if you know the hemodynamic profile, because you are going to collect this and select the correct therapeutic strategy based on the hemodynamic profile. That is very, very important. So it needs a multidisciplinary approach, and we need a simpler classification so that it is easily acceptable by all the specialists to carry out the correct therapeutic strategy. So this is one thing. The other is the hemodynamic profile. These hemodynamic parameters can be measured both invasively and non-invasively. At the bedside itself, you can start doing echo and collect all the hemodynamic parameters what you are going to get by the invasive method. For example, all the parameters what you need is the RA pressure, pulmonary systolic pressure, pulmonary diastolic, pulmonary capillary pressure, cardiac output, cardiac index, then systemic oscillator resistance, pulmonary oscillator resistance, and the more important latest indicator is the cardiac power output or the cardiac power index. All this can be done, can be non-invasive at the bedside. So this is very, very useful. But what is the use of this invasive hemodynamic monitoring? That is very, very better, accurate compared to our non-invasive, and also very useful to know whether the patient is improving, when to wean off the patient from all the support devices. All these things very useful for with the hemodynamic, invasive hemodynamic monitoring. But however, unfortunately, only 10%, less than 10% of patients undergo this invasive hemodynamic monitoring, even in Western countries. So leave alone our country, even Western countries, they don't do routinely this pulmonary catheterization for measuring the hemodynamic parameters in cardiogenic shock. So this is all very important. And why this? Because the hemodynamic profile, based on this, you are going to select which inotropic is the best for the particular patient, which one to start first, then how to escalate. Then suppose we are to start inotropic which has got a vasopressor activity, or start inotropic which has got a vasodilator activity. So all these things can be done with if you know the hemodynamic profile. And also when to start the MCS device. That is very important. So when you start MCS device, which one to start first in a given patient, which is best, then how to escalate. So that is another important thing. And also when the patient is on MCS, suppose the patient is showing improvement, you should also know when to stop, when to wean up, how to wean up, all those things. And there are various MCS devices, each has got some plus point and minus points. So for a particular patient, which is the best one, we have to assess and then select the MCS device. So all of this, our guest speaker is going to highlight the entire crowd with all this experience, and he will also go and guide us how to start a multidisciplinary protocol for a patient with cardiogenic shock, acute pulmonary embolism, and we are very, very delighted to hear from him. So I invite our guest speaker, Dr. Kamlesh Anbalagan, to come to the dais and give his lecture. And before that, I would like to ask my colleague to introduce the speaker to the audience.
Thank you, sir. That sets urgency and direction clearly. Excellence comes from experience and execution. I request Dr. Chakravarti to introduce the lead discussant, Dr. Kamlesh Anbalagan.
Good afternoon, all. It's my privilege today to introduce our guest faculty, Dr. Kamlesh Anbalagan, to this wonderful scientific session. Warm welcome, sir. Dr. Kamlesh Anbalagan has completed his undergraduation MBBS in first class of honors from Yang Lin School of Medicine, National University of Singapore, and done his Master of Medicine from National University of Singapore, followed by he's done his membership of Royal College of Physicians, MRCP, UK. And his main core clinical interests are critical care medicine and cardiac intensive care, advanced heart failure and cardiogenic shock, mechanical circulatory support and ECMO, echocardiography, and continuous medical education to the undergraduates and postgraduates. He has his professional appointments. He started his career with National Health Centre, Singapore, and presently he is working as a clinical assistant professor from Anglo Lin School of Medicine from July to till date. And he is committee membership, and also he has many roles in his present organization. He is a member of Sing Health Rapid Response Team, and also he is member of Sing Health Code Blue Committee, and also he is lead NHCS Telemetry Work Group, and also he is lead to the NHCS Shock Team, and also he is member of NHCS Pulmonary Embolism Rapid Response Team from Jan 24 till date. His educational leadership, he is director of 9th Coronary Care Symposium in 2024 from NHCS, and also faculty of 19th Cardiovascular Update 2025 NHCS, and so on. For his accomplishments, he has received various awards, and I'm going to mention some of them. He is outstanding faculty from Cardiac Senior Residency, Sing Health from 2023, and also he is Bronze Patient Service Award from NHCS from 2022. He is outstanding resident Internal Medicine Residency, Sing Health from 2018, and also he is the Dean's List, Yang Lin School of Medicine from 2011, 12, 13, and 15. And according to his, in his research interest, he has various publications in cardiogenic shock and also in pulmonary embolism in various journals, in famous journals. With this glad introduction, I request Kamlesh Anbalagan to take over the stage and enlighten us today with his wonderful scientific session. Thank you, sir.
Thank you so much. It's really an honor for me to be here, and I would like to thank Billroth Hospital for inviting me. Let me just get my laptop set. Okay. If I can change the slides. Okay, so I think the main role of this session at this point in time is to discuss how to come up with shock protocol. How did we in National Heart Centre Singapore come up with shock protocol? Why did we come up with shock protocol? And also the PERT team. Why did we come up with it and what was the purpose? Now, the shock protocol for us looks something like this. This is what we created. It seems very simple, but it took us about 4 years to get something out like this. This is version 10 actually. And the reason why it was so challenging is because there are many, many stakeholders that the previous speakers have actually alluded to. So it's very important to understand that in the end of the day, when you come up with a protocol, you must have a purpose. And the purpose is to reduce time to action, time to diagnosis, and time to intervention for cardiogenic shock. So that's the most important purpose of the shock protocol. So why do we create a protocol? Now, I purposely show this slide really because I want people to understand when you get to the table and you say, look, I'm going to now come up with a protocol, you must ask yourself, what is the goal? So I can tell you that my goal was based on my experience managing ICU patients when I come in the morning at 7 o'clock or 6 o'clock. And you see that the patient has been managed, has been in shock for about 8-9 hours. And most of the important decisions are being made only 8-9 hours later. Right? So that was a problem. Now, when that happens, what you have is multi-organ failure. So multi-organ failure is something that you can't necessarily always reverse. There's a point of no return. Now, once you hit that, it doesn't matter what your hemodynamic data shows. You realize that you cannot alter the variables anymore. This is very important to understand. Second thing is this. All of us have bed pressures, right? It's no different anywhere in the world, right? So you only have that many beds. And if you have only one bed left, it will affect the way you manage the next patient, right? So efficiency is also very important. So if you have multi-organ failure, right, the time taken in the ICU to recover is going to be much longer, right? It can be in terms of weeks, months. Sometimes, administrators, the guys who sign the checks will say it may be better the patient passes on rather than drag on very long, right? And the long-term sequelae that they have. So when we came out with the protocol, we asked ourselves, what is the goal? So the goal was, number one, to prevent multi-organ failure, right? Whether we could show there's ICU length of stay reduction, difficult to say, right? Because we want to show we reduce multi-organ failure, and then we hope that that will reduce the ICU length of stay, and hopefully that will also reduce mortality down the road. Now, when you come up with a big workflow with multiple people inside, you have to show data. You can't show data 5 years later, 10 years later. You have to show data quite quickly, right? So if your goal was to reduce mortality, say, look, I'll reduce mortality, and you give a 3-month data, you may not be able to demonstrate that, right? Because only 5% of patients, for example, for AMI come in with cardiogenic shock, right? So numbers per month may not be that large. All right, number 2 is the consistency in the care you deliver. So you'd realize that different consultants have slight different strengths. It's not that they are lousy at something or strong, but it's just that the nature of our training, right? So medical ICU people have certain strengths, SICU people have certain strengths, cardiologists have certain strengths, right? So in the end of the day, when you have a cardiogenic shock patient, you want to have consistency so that your outcomes are good. Now, what I don't like is adjudication of MCS devices. So this is something that I really don't like it, because if you look at Western style of shock protocols, how they create these protocols, it's very much to decide a bit of checklist. Okay, impeller goes in. Checklist, ECMO goes in. Now, in reality, can we do this? No. Because if you do this, you're going to run out of money, right? You're going to run out of beds, and you're going to just basically have a very, very difficult fiscal policy, right? Because everybody needs a impeller. So when I look back at the data before we came up with the protocol, we say, okay, look, let's say we use this, Detroit shock protocol, right? How many, the percentage of patients will require treatment? It triples, quadruples very easily. Definitely not something that is reasonable. So how do we start? So we start by identifying the problem. So you need the data first and foremost. Number 2, ensure all the stakeholders are involved, right? This includes people that you may not think is important, like administrators, right? Because if your protocol runs into trouble, right, they're going to clamp down on it. Or if you need approval processes, right? If you have done meetings for 6-7 months and then suddenly they say, hey, look, this is not suitable for us. Again, all that effort is wasted. So you have to involve everybody when you come up with a program. And that's also one of the reasons why it takes so long. It takes years sometimes to create a protocol. And always review the existing workflow, right? Every center is going to be slightly different, right? So certain capabilities are there in certain areas, certain capabilities are not there. So you cannot, again, have a cookie cutter kind of approach where everybody follows this standard template. So for us, so when we looked at shock survival, so again, the same as literature, right? 50% roughly for all comers. All means heart failure, cardiogenic shock, AMI, cardiogenic shock, roughly around that, 45 to 50%. So we do this thing called peer review learning on mortality cases where we think we could have done better, right? So that we learn and at the same time we also adjust workflow to ensure that these kind of things don't happen again or we improve on what we are already doing. So we used to do quite a number of this and I will show you an example of something that we did. And a lot of our ICU length of stay for most of these survivors tend to be very long, so about more than a week. And eCPR survival was abysmal. In fact, it was so bad. So in Singapore, it's a small country, right? You cannot compare to India. It's a very small place. It's just a city. So we have 2 ECMO centers. So roughly we do about 140 ECMOs, of which cardiogenic shock comes to about 50 ECMOs a year. So when they look at the data, when MOH looks at the data, the Ministry of Health, they see, hey, your eCPR survival rate is terrible. So they put a lot of red lines on when you can insert ECMO. So that immediately took us away from doing eCPR. eCPR numbers crashed, right, because survival was just so bad. And a lot of the survivors, their cerebral performance category, that means how well they were able to do their day-to-day life, very bad as well. So it was a problem. So we did very little eCPR, and if you did eCPR, you have to justify why you did it. So I'll give you a classic example of a case in 2023. So I'm just going to, this is exactly the slides that was presented. I won't go too much into details, but basically 68-year-old man, right, sudden onset shortness of breath, no chest pain or anything like that. Blood pressure as advertised here, 102/64, and he seemed to be slightly drowsy but arousable, a bit strange for someone 68 years old with no brain issues before. ECG basically shows this, right, massive MI. And the laboratory shows elevated troponin, there is some AKI, but otherwise lung fills are okay. Very, very early presentation, right, within 2 hours he came to the A&E. So cath lab was activated, DAPT was given, and as expected, the blood pressure started to fall whenever you're starting to move the patient. So they moved to the cath lab, they started dobutamine first, and once transferred, the BP was about 94/50. And in the cath lab, we saw this, right? So you can see that the left side doesn't play. Yeah, so this is the nightmare for interventionists, right, when they see this. So clearly, this is the reason why the patient's blood pressure was low, and the likelihood of cardiac arrest is remarkably high. So, as usual, what everybody does, they get quick access, they put in the IABP, they got CTS at that point in time to discuss whether CABG was an option, was declined, and then subsequently went on to do PCI. So PCI was performed, stent was placed, and then there was a plan later on to do a relook cath and as well as PCI to the RCA. Now, this is the part that was of interest to me. Because when the patient arrived in the CCU, they were oliguric. Not surprising, right? Very common. Lactate was actually progressively rising. So the patient came roughly about 7 p.m. Progressively overnight was rising. Vasopressor requirements was also going up. And the bedside echo 10 to 15%, no mechanical complication. MAP was 65 to 70. The magic number was met, right? So it was kept there. Eventually, at about 7:50 a.m., the patient's blood pressure tanked, triple vasopressors. ECMO team came. They had difficulty cannulating the vessel. Eventually, they lacerated. There was bleeding. Patient was put on VA ECMO, but he didn't survive. 9 hours passed from point of admission to the point of ECMO activation. So why am I telling you this? Because this is a problem. Right? So this is a patient that stayed many days in ICU on ECMO and eventually still died. Huge amount of resources were used. But the question is, why was there a 9-hour delay? Was that something reasonable. And we have many of such cases. So that is the problem. We showed the data, and we had an idea that, look, shock protocol, compressing time, intervening early, right, looking at parameters in a more granular fashion, right, trying to decide what can I do to have gotten this patient better support. Right, so all stakeholders must be there. So now I put things like call center. Why is this important? Because when you're going to have a shock team, shock happens anytime. In fact, it always happens when you're having lunch, you're having dinner, right? That's when the phone rings. Now, the call center, at least in my institute, right, basically activates the different stakeholders that are on the roster. Right, so this includes surgeons, the interventionists, the ICU physicians, everybody comes together. So the call center has to be involved because they need to know, okay, how do we activate? So how it happens for us is that we get a text. If I press 1, I have acknowledged it. If I don't press, call center will call that person and say, hey, look, there's an activation. Can you look at your phone and acknowledge? So this is important. So you need to see whether they have the capabilities to do this. Number 2, emergency medicine, right? So most of these patients, especially AMI cardiogenic shock, they present in the ED. Right, so the A&E physician needs to be well educated in the workflow of what happens when they have a cardiogenic shock patient. What is the priority? Right, for example, we mentioned sky staging. Right, sky staging requires perfusion markers. So you have to discuss what are some of the things that you need from them. Registrars, of course, the junior folks will be there seeing the patient. ICU, cath lab nurses, CTS colleagues, ECMO, advanced heart failure team, mainly because you need to see whether the patient is a candidate for long-term durable support. Interventionists, and of course administrators. So specific points that I had difficulty, right, pushing through. Who activates the group? Right, so this is actually very, very, very important, and I'll explain this in a little while. Who should be in the group? Should 50 people be in the group? Right? What platform are you using? Are you using WhatsApp? Are you using Tiger Connect? Are you using Teams? Again, this is very important because there are limitations for each of these devices. Is the call center involved, for example? Should everyone know every aspect of the protocol? Is that important? And how do you manage if you're a referral center? So you have peripheral sites, right? How do you manage that? Then what is the capabilities the same? So for example, you may have 2 peripheral sites, but one site can do something, one site cannot do something. Right? And of course, the complexity of the protocol. If your protocol is very complicated, the first version of our shock protocol was 6 pages long. Completely useless. Because the people who made the protocol, they know it very well. But once you put it down in the A&E, you put it in the wards, people can't really use it. It's not very useful. So who activates? Now this is something that I can tell you that we learned the hard way. So we wanted the referring guy to activate, which was a terrible idea. And we learned it actually from PERT, because PERT came earlier. What happens is that you don't want the A&E physician, for example, to be the one activating. Makes no sense. Because that guy is doing all the hard work. He is diagnosing, he's resuscitating, he's setting lines, he's doing all sort of taking consent, for example. He's doing a huge number of things. He cannot be then activating the shock team. Right? What he does, he will activate the cardiology registrar. So for example, for us, cardiology registrar comes down. The cardiology registrar is a small number. They know shock very well. They are trained in this. They can make assessments looking at the inclusion-exclusion criteria without looking at the paper. They know this is the inclusion criteria. Right? This is a shock patient, they will activate. So once activated, then everybody involved. So who should be in the group? Only decision makers. So if we don't want people there and disturb them in the middle of the night if they are not going to be able to contribute, right? So, for example, A&E physicians. So A&E physicians, they have identified, they are in the early part of the protocol, but I don't have to include them thereafter. They have trauma cases coming, they have pneumonia cases coming. They are not going to be able to entertain questions and all that kind of thing. Right? Makes sense. So we don't include them in the shock protocol, but we discuss with them when we create the protocol. Right? It's very important. Because without them, it doesn't exist. Right? ECMO team. Now, ECMO team and all this, we include them straight away. Reason is because, first and foremost, is the patient a candidate. For example, he is 71, borderline age. Our cutoff is 70. Right, but he's a very good 71. You want to have this discussion. You can't have this discussion when the person is almost at the point of collapse. It's very difficult. The surgeon will just say no. Too far gone. Can you blame the surgeon? Cannot. Because if you are in his situation, you will say the same thing. Right? It's true. So ECMO team is involved immediately. The case is run through with them. They know. And once the trigger point hits, they will come. And in fact, we plan. So the ECMO team will say, hey, look, this guy looks like he's going to get it, Why don't you put in the access for us? So we don't want eCPR. We want to put the ECMO before CPR ever happens. And I can tell you, for any of the surgeons or interventionists, it is very difficult to set lines when someone is pumping the chest, when you've given high amounts of norepinephrine, vessels are very small. It is not easy. I mean, it can be done, of course, right? With experience, you can do it, but why if you don't have to? So we get the ECMO team in very early. Other members sometimes are required. So my most recent case that I had, very, very exciting case, and it's a good outcome, that's why I say exciting, if not it would be very disastrous, is a 40-year-old lady with crash landing pulmonary hypertension. Right? So we included the PH team, and we use Teams in our side, so we can actually show the history of the discussions that happened before. So she's not an ECMO candidate, Group 1 PH from ASD. Clear cut, they will not do ECMO for these patients. It's a contraindication. So we had a PH team in, and she did well. She survived, and she went back home. Advanced heart failure team sometimes are important. Myocarditis patients, for example, biopsy plans and all this. So they may be involved. Now, in the end of the day, there has to be a leader. And the leader doesn't have to be like, here, I put ICU doctor may be the best, because in the end, he's the receiving person, right? And so a lot of times, they are also cross-trained, tends to be cross-trained in many fields, so it's easier. You don't want, for example, the interventionist to be the leader, because he has got a stressful job of getting stuff in, doing PCI and all that kind of thing. So if he is also having to entertain conversations, very difficult. It's not fair. He can be as good as the leader, but it wouldn't make sense, because the discussion will be tough. Right? So you need a leader. And why you need a leader is because you don't want a situation where no one is communicating. Everybody's just talking, and you just see line after line, but there's no one taking charge and say, okay, we'll do this. Right? So that's important. So what platform you're using, I've said this is very, very important. So if you're using WhatsApp, you have to know the limitation of each of these things. Okay, should everyone know the protocol? So this is something I alluded to. So A&E physician, right, don't need to know what the interventionist is doing in reality, right? Interventionist generally needs to know everything, because he's the end point where decisions are made, right? Whether MCS is required, not required also. So they tend to know everything, but do you want the interventionist to say, hey, should we intubate this patient and all that? No, not really, right? Let him focus on the procedure and everything. The rest of the medical side decide on what to do in the earlier stages. So we tend to have kind of clear roles for everybody. Eventually everybody becomes very good friends, and sometimes one of us are not around, someone else takes over. So you realize everybody learns from each other and everybody becomes good together. So how do you manage different sites? Now, if you are going to transfer patients, right, who are quite ill, actually the position of where the ECMO team is, for example, or the MCS team is very important. When do you intubate becomes a very important question, right? What is your vasoactive plan becomes very important. So I'll tell you something that we are working on. We haven't reached it yet. We're still talking about this. We want to have prime ECMO circuits in the peripheral center. Singapore, easy, because very tiny place, right? Even the furthest distance, so it takes an hour. So we want to have prime circuits so that surgeons don't have to put the machine in the back of their car or the taxi or something and drive down to the place, right? Interventionists are very good at putting cannulas in, so they can actually start doing all those things. The surgeons come in and outside, and then takes over the case and transfers over. So these are things that we think about as we improve our processes. And always have a champion at every site. So if you are the main center, right, don't talk and say, look, you do this. It's very difficult. Because they will have different people coming around. It's hard and it's very challenging. So you must involve them. You must have a champion from every side that helps you actually on the side to make sure things go, make sure work processes are there to support you, right? So it's very important to have a champion at every side. Now, last is complexity of protocol. So if you have very complex assessments to be done, for example, I put here venous lactate. So venous lactate is something that we did because we know once lactate is high, outcomes are bad. You're already behind the curve. So we introduced venous lactate. Initially, they wanted to put an arterial line, look at the eye line pressures and all that. Actually, it's not very reasonable. If an A&E physician has a trauma, has a septic shock, and has a cardiogenic shock, he's split 3 ways. It's very difficult, right? So all we say, look, you're going to do labs, you're going to put a cannula. Just put it and give us a venous lactate. Venous lactate is high, you got your sky stage there very nicely, right? Before you can even get, the rest of the labs are not going to come out so fast, right? It's going to take, even your troponin doesn't come out in 5 minutes. It takes an hour to come out. So, but venous lactate immediately gives you an idea where the patient is, right? So it's very important. PA catheter. So PA catheter, a lot of people talk about PA catheters. I've gone to many conferences. People say, oh, PA catheter is the best thing, put it for everybody. Reality is, yes, PA catheter is fantastic. So we float it bedside. We don't actually even ask the interventionist to put it in for us because they go through groin, right? They don't put in the neck. We actually put in the neck. We float it. We don't even use fluoroscopy. We get it in about 15 minutes, right? And we do it very methodically and everything in the ICU. And it's very, very useful. But the truth is you cannot mandate in the protocol that everybody gets a PA catheter. I can tell you what will happen. And this has happened, right? What will happen is that the guy has many priorities. He will need maybe he needs intubation, maybe he needs dialysis, but you will see someone mucking around putting in a PA catheter. So I'll give you an example, RV failure. The patient has pulmonary embolism. That's RV failure. The treatment should be to treat the pulmonary embolism. People putting PA catheter. Makes no sense. So you have to give some flexibility to people when you create a protocol, right? You cannot mandate certain things which become very cumbersome for them. So that is something that I think is very important to understand as well. So if you look at our shock protocol, first things first, what the A&E physician needs to know is that he needs to know, look, what are the indications and contraindications for certain devices? Right, so if you're going to call for eCPR and the patient's 80 years old, for example, it's not going to be a good thing. And it's also important because it also forces them to use the ultrasound for every cardiogenic shock patient because they look for AR, they look at heart function. We don't need fancy numbers, we don't need TAPC, we don't need any of these things. Just tell us what is EF impaired? Is there AR? Is there anything else you're thinking about? Is there any mechanical complication? That's it. We will verify as well, of course, right? It's very difficult to do echo in very sick patients. And A&E physicians actually see quite a lot of this as well, right? In fact, they see more shock, more varied types of shock than us. The next thing then is the diagnosis. So once the diagnosis is made, the registrar comes down and sees the patient. Then he has a very simple decision to make. So he will see, okay, is this patient's perfusion affected or not? And you will look at lactate and physical examination. Don't need to do anything fancy, right? If it isn't, they go to cath lab, everything is per normal. If there is, then they activate the shock protocol. So once the shock protocol is activated, see the Teams chat will be there, right? They will start initiating, peripheral vasopressors and all that kind of thing. And we will discuss certain things. So we will discuss, first of all, what stage they are. Now, this was a big challenging point for us because people were coming up with all sorts of numbers. And in the end of the day, what are some of the important things? What is our drug dose? What drug dose are we going to give? And number two is whether the patient can move, whether we should intubate the patient early. So these are things that we decide. At the same time, we will let the ECMO team will be involved, right? So if they think that the patient won't be able to move, they will go straight to the A&E, right? If not, they will meet in the cath lab. Our goal is always to get the patient to the cath lab, scoop and run, rather than plug and play in the A&E, right? Because if you ever seen ECMO insertion in A&E, it's not very easy to do, right? It's very messy and people are not familiar, right? The surgeon is going to a new environment to do something, right? Equipment will be a little bit different. Cath lab, we have fluoroscopy and everything. It's a lot easier. So that is something that we do. Then finally, of course, the parameters. So we have, when we do decide to do any of the devices, whether it's impeller or VA ECMO, then of course we have numbers that we work with. It must, in the end, there must be some adjudication. It cannot be zero, right? Not everybody will trigger happy and put something in as long as the patient's unstable. So there are some numbers there to ensure that it's not put in too early. And I can tell you a lot of times, patients' cardiac index, especially if you look at heart failure, patients with pre-existing heart failure, the cardiac index is always less than 2.2. We have quite a number of those cases. We don't put ECMO for all of those cases. So it is something that we look at, and then we decide at that point in time, okay, look, patient is getting better, there's no refractory shock, we transfer them back, but we have a PA catheter, we have what we call flow-targeted resuscitation, which I'll talk about later in the evening, that we look at to decide whether the patient is getting better or not. So you must have reassessment. So that's very, very important. So this is the shock protocol. I just want to quickly show also the PERT protocol that we have. Looks a bit small. Can I show the screen? show the screen? So the PERT protocol is very similar. It's also very graded. It tells people how to do the assessment. I think it's here. Close the slide. This is not a slide, it's a picture. Sorry about that. So the PERT protocol, again, very simple. So it actually looks at inclusion criteria, right, exclusion criteria. It tells you that initial treatment, like for example, not this one. PC screen. Okay, so this is the PERT protocol. So again, you see, it doesn't activate everybody, right? So what it does is that it basically tells you that once you confirm the diagnosis, right, if it is low risk, that sort of thing, we may not need everybody involved, right? And it guides the person. What is the contraindication to thrombolysis? You know, what's the relative contraindication? How do you calculate the score? So when they call us before they activate the PERT team, we will tell them, look, this is low risk, there's nothing much you need to do, or this is high risk and something needs to be done. So our center, for example, is a cardiac center, right? So we don't get many PEs. Most of them get admitted to the main hospital. So our protocol, we very rarely have to use. Maybe, I would say, once every 2 to 3 months. So it's quite uncommon. But I show you what a multi-center kind of a larger hospital, how it looks like. So this is their risk stratification, right? So again, once you confirm the PE or a very high index of suspicion, right, they will ask you to initiate anticoagulation, right? This is the biggest problem because a lot of them, they don't initiate anticoagulation. They wait for the PERT team to guide them on what to start. So we don't want that. So when we created the protocol, the original protocol didn't mention this. They say activate PERT, then they left it there. Then PERT discuss, and somebody will ask, what anticoagulation is the patient on? Oh, we haven't given anything. And everybody gets very worried. So it's very important to understand that. The second thing for our PERT team is that we actually again involve the ECMO team. So if a patient has intermediate high risk or high risk PE and they're going for example, catheter-directed thrombectomy, what happens is that our ECMO team will actually be there with a prime circuit while they're doing the procedure. And pre-procedure itself, the cannulas are inserted. If the patient has a cardiac arrest, they will just start. Almost every patient that has collapsed while during the procedure when we did this, they survive. They go home in the end. Simply because they don't have multi-organ failure, and once you have put this in, you suck out the clots, you support them for a few days, and the ECMO comes off very nicely. So So the protocol has evolved over time, but you can see that both the shock protocol as well as the hurt protocol are very simple, very easy to use, and they're not rigid. So I think that is what I would say is the most important thing. Last thing I'm going to show is the RV failure management. I shouldn't use the word protocol. I think in the end they use the word protocol in the policy document. This is a document that I wrote in 2024. And really what this is a clinical guide. Because we realize that patients with cardiogenic shock with the subgroup of RV failure, those are the patients that really have very high mortality, because the things that we do for LV failure, if we do for RV failure, it can be fatal. So it can be fatal. So like the last case that we had, the lady, is a very strong, feeling about intubating this lady, right? She's respiratory rate 45, saturation 60, pulmonary hypertension. But I can tell you at that point in time, if we had intubated her, she would probably have a cardiac arrest, no matter how good the intubation was, no matter how much you plan. So what we use is high flow nasal cannula at that time. We started this workflow and the patient got better. So eventually she recovered. So you need to also have workflows for rarer conditions, because if you don't have it, then what happens is that everybody is not so familiar and it becomes very challenging. So with that, I will stop, and because I think in the end this is going to be a discussion. So I was hoping to see whether there's any points anybody wants to raise or any questions that they have with regards to some of these things. Later on during the scientific meet, I will talk about how we managed it in the ICU, and also how this RV failure policy works, and how we use it in day-to-day practice. So any questions anybody has, or anything that they want to discuss in specifically with regards to cardiogenic shock protocol or RV failure, or even PERT activations and PERT protocols? So it's supposed to be interactive, because I really do want to know, for example, what the current workflow is and how we can actually help to facilitate creation of these protocols.
Can we have... Good afternoon all, and so thank you for all the way coming down and enlightening us. Just I would like to share one or two examples, clinical examples, and then rather asking questions. Just I would like to know what would be your stand in this given scenario. Say patients either acute myocardial infarction or per se the massive pulmonary embolism kind of patients. When they come and collapse, hemodynamically unstable, and when you resuscitate based upon biochemical parameters, altogether a different story. The one which you shared, for example, ostial left main occlusion and then ejection fraction 10% and unimaginable biochemical parameters. So where do you draw your line? You continue your ECMO or whatever the protocol, but in the inner mind, I have the suspicion that this patient will just pass away. Or this person is going to make it. So as an operator, I would like to go and, apply all the forces and then see that he is coming back. So exactly what I wanted to convey. If I choose 4 patients for ECMO, and then if none of them making it, then it is really disappointing us. So I don't want to do it for a customary kind of practice. In this scenario, when someone comes and collapses at your door, exactly where do you draw a line, at least in your inner mind? Let us go ahead and then fix that case, that is different. But we should know whether they will come back or not. So what is your drawing line between the two?
Very good question. In fact, that is exactly my thoughts as well. Because you see, the problem was, even when you look at eCPR data that we had, right, and I purposely go to this slide because I did expect someone to ask something similar to that. What you realize is that if you are too late to the game, And how do you define too late to the game, right? The patient will die no matter what you do. You can do the most perfect PCI, you can do ECMO implantation very smoothly, but the patient still dies, no matter what you do. And you see they are very vasoplegic on ECMO, they are giving fluids, they have very high vasopressor support, and eventually they don't make it. So what is our red lines? So our red lines are very simple. If a patient arrives in the A&E with cardiac arrest, it's very clear. We will only put ECMO if the patient ROSC and actually shows signs of intact neurological function. Now you think, that is terrible, right? I mean, there are a group of patients who may have survived. But the thing is this. So our local Singapore data, and it will be the same everywhere, what we noticed is that we have about 2,000 over cardiac arrest patients, out of hospital cardiac arrest patients in a year. Right? A small percentage of them make it to the hospital, and even smaller percentage of them go home. Now, what was more interesting when you look at the numbers is that it is the time to CPR that makes the biggest difference. It's a massive difference. In fact, if you have 12 minutes lapse between the patient found collapse and CPR initiated, it's 100% mortality. We're not talking about vegetative state, 100% death. Right? They will not make it to the hospital. If they make it to the hospital, they will be pronounced in the hospital. Right? That's what we have seen. Patients between 5 minutes to 12 minutes, generally you will have some degree of neurological impairment. Patients below 5 minutes, some of them do survive. Right? So this is very important. So what do we do is if a patient arrests in front of an A&E physician in the A&E, he arrests in front of an interventionist in the cath lab. If the patient arrests in the ICU, high dependency, ICA, now the people who are intervening and doing the CPR for these folks, these are trained professionals, right? They know how to do CPR, they don't wait around, they will have, the nurses are all prime, everybody is prime, everybody knows what they are doing. You will realize you can have a downtime of 90 minutes. And this is true. 2024 December, I had 2 eCPR cases. One was a 36-year-old guy, at that point a 34-year-old guy. The other one was a 29-year-old guy. One guy was playing cricket, the 34-year-old guy was playing cricket, collapsed. His friend immediately started doing CPR, brought him in, he ROSC for a short while, in front of A&E physician, collapsed again. Total downtime, I think 64 minutes. Initial CT brain showed early HIE changes. The other one was a 29-year-old construction worker, very fit fella, smokes a lot, plug rupture, 96 minutes downtime. Again, arrested in front of the A&E physician. Both walked out of hospital. There are early HIE changes, one had myoclonus and all that. That's why I can tell you all these signs that you see are all rubbish. They're all rubbish. Because in the end of the day, what is important is that was the resuscitation done well? And if you decide you are going to bring him to ICU, then there's no point being half-hearted. Right? If it's half-hearted, then just let him die. Don't waste your time doing resuscitation, all that kind of thing. If you are going to rescue him, you have to put in 100% effort. If he dies after that, it's fine. But who are these patients? Patients who arrest in front of you. Patients, of course, short downtime is the best, but time to CPR is something very important. Our ECMO consultant, for example, when he goes down to A&E, he looks at end-tidal CO2 as a marker of good CPR. Or if it's, let's say, done in the ICU, patient intubated, good end-tidal CO2 is mentioned in the literature. It tells you that there is some circulation. Right? So these are patients that should be put in ECMO for. So if you look at our data, right? So why do I did this data? So when you do this protocol, administration will say, look, you are getting a lot of people involved on call. You have to show us that it makes a difference. So our survival, 30-day survival, right, for 32 consecutive shock patients, for all comers, that means heart failure or AMI, was 65.6%, right? The ECMO survival group, that means a group of patients within this that had ECMO, 70% survived. What was interesting was eCPR survival was 60%. We had 5 patients that had eCPR, right, and 3 of them actually survived. And so this is very different from what we had before, where most of them, almost all of them died. So patient population roughly around there. I think the age, I forgot to put it in, but the age was roughly in the early 60s, right? But you can see that the patient population, high risk profile, and everything. But the survival rate was quite good. So we did, in the whole of 2024, 29 ECMOs for cardiogenic shock. Pure, that means not post-surgical cases or anything like that. Pure cardiogenic shock. Survival overall was 62%. So in the end of this, selection is important. So what you're saying is true. If a patient has arrested, every arrest case you go and put in ECMO, you are finished. Right? You won't have bids, you won't have money, and the administration will shut you down. And it's very fair for them to do that, right? Because we live in a world where there is resource constraint. So I will say that our red lines, very simply to answer the question, time to CPR very important, where the patient arrests is very important, who is resuscitating is very important, and location, right? Location is very, very important. So if a patient was in a general ward, nurse was doing a routine 4-hour vitals, patient was found unresponsive, sorry, no ECMO. So that's our red lines, I would say. I think the mic is not.
Yeah. So one thing which I'm curious to know is when the patient presents to ER with an impending shock. I'm not telling established ECPR is a different this one. If he's presenting with an impending shock, are there any objective parameters you have, like you told venous lactate, which is protocolized? Like he comes and he's an impending shock and we do those parameters and we put him into the shock protocol and escalate. So is there anything which is like 2-3 things which is followed in the ER, I'm telling?
So that's a very good question. So what we do is this. So in the ER, so like I mentioned before, I specifically mentioned the scoop and run versus plug and play thing. The reason why is because it is very tempting to ask the A&E physicians, for example, get the IA line in. We look at the arterial blood pressure response, right? You have beat to beat. You can look at diastolic pressure for vasomotor tone and all that. You can do a lot of things, and I will explain some of these later on in the evening as well. But the truth of the matter is that you realize that the patient will get stuck there for very long. Because who's going to save the day? The guy who's going to save the day in the AMI cardiogenic shock, for example, is going to be the interventionist. Right? So all these things that we are doing is not so useful. So why we settled on lactate is because it reduces the time the patient spends in the A&E. So we want the guy up to the cath lab as soon as possible. Once they are in the cath lab, what the interventionist does, of course they look at what vasopressors are there, what's the sky stage. All this information will be there to him. The echo parameters will be there to him. Echo parameters we know is not the most useful, but at least contraindications for certain things like, for example, IBP, the severe AR and all that, those information will be there for him. So what he will do is that he will put in IBP if the blood pressure is low or something like this, get the LV EDP readings, right, if the patient is really crashing very badly in front of them. If they are truly crashing at that point in time, they will get an ECMO team to come down and at that point in time cannulate the patient. But if the patient has some stability at that point, they will continue intervention. Post-intervention, they will do a PA catheter run. And the PA catheter run can be done in the cath lab or it can be done in the CCU. So that's the parameters that we get.
That is what even I was thinking. See, the thing is when they come to ER, many of the ER residents waste time putting the arterial line because of course it gives us good this one, but that is the time wasted. So I think the non-invasive parameters are suffice to put them into the shock algorithm. And echo, I think it is indispensable. The basic echo, what we need to do, I think it is indispensable. Second question, little controversial, like the patient, you have told that, yeah, I mean, the primary team or I don't know, the first call, we have put him into a shock protocol and he is escalating SCA, he is going into D and E stages and time has come to initiate MCS. And the shock team, if there is a disagreement between the shock team, whether we need to escalate to MCS or what kind of MCS. So who is the stakeholder? So I am curious to know who takes the final decision.
Yeah. So it is a very good question. And I can tell you that this was something that I was very worried about. when I created, right? So there's ECMO director, right? There is heart failure specialist and all that. So everybody is senior, everybody is good at their job. And I was quite worried that, look, if the intensivist takes the charge and makes decisions, there will be unhappiness, there'll be fighting and all that. Surprisingly, there wasn't. In fact, people are quite happy to defer these high-stakes decisions to team leader, for example, or whoever who is willing to take up the thing. So surprisingly, it wasn't very difficult. But what I will say is this, you need to have red lines. When it is a clear, look, our stance is that we will not put in ECMO. So for example, group 1 PH, right? So group 1 PH, technically speaking, uninitiated, you see case report, people put ECMO and they start, PH therapies. But we have decided that, look, this group of patients, the mortality is going to be very high. So if they do require ECMO, we just say, no, we are not going to do it. Our age cutoff is 70. We allow a little bit here and there for patients who are really functionally quite good, but beyond that, no. So there has to be a red line. So red lines crossed, you cannot then say, look, the ECMO consultant, for example, he is the one who takes responsibility for putting in. So if the age, for example, is 74, and you say, look, I think this is a good 74, you should do it, I usually leave the final decision to the surgeon who is inserting, because it's not fair for me to say, look, you have to break this rule, put it in, but then you also have to answer to ministry when they say, hey, why this patient 74 breached the age cutoff, but you put it in. And he cannot answer the ministry and say, oh, the intensivist asked me to put it in, so I put it in. You can't do that. So it's very important that it is a team. Everybody makes a decision together.
I agree. I think the controversy, I will not say controversy, I think the debate will come because it's very resource intensive here. That's the only place I think this one will come. Whether it's going to really benefit the patient or whether how short term it is going to be, how long term it is going to be. I think that is where the confusion will arise in our setup, I think. Yeah. Lastly, I have one more question. Do you have any shock registry? The patient comes into the shock and you treat it with whatever maneuvers and he goes out or he succumbs. So whether every patient gets into a shock registry so that we can retrieve those data for our own improvement or for prognostication or for any other research purposes. So is there anything shock registry which is maintained?
Yes, so we do that, and I think it's important because in the end of the day, right, whatever protocol you do, you need to show data, unfortunately, right? So you should have it. So how we did it, initially we were very ambitious. We wanted to say all patients, based on parameters, we label them as, let's say, SCAI, C, shock, they will be put into the protocol. Very difficult. Because the truth of the matter is there's so many patients, there's so many humans that we are dealing with, the accuracy of the data is not so good. The guy was SCAI C at one point, SCAI D at one point, and the numbers are all over the place, documentation can be all over the place. It is a stressful situation. So what we decided is that if the patient gets activated, that means the shock team gets activated, immediately they will be put into a workflow. So that's what we did. Because there are, give an example, inferior MI. They will come in very hypotensive, A&E physicians will put in a cannula, they will flood the patient with fluid, BP will stabilize, we will go from SCAI D to SCAI C, and then they will quickly rush to cath lab, PCR will be done. Patient sometimes a bit bradycardic, deep temporary wire goes in, but 3 to 4 hours later they are perfect. So this group of patients, we actually, most of the time they don't activate the shock team at all, even though initially they seemed very unwell, because they know the trajectory, the patient will get better. They don't want to activate the whole gin gang of people for whom they know that most likely they won't be involved. So those patients that they don't activate, we don't actually put in the registry, but if they do activate, we put it in. So there is a selection bias. But the problem why we cannot get rid of this is because of how do we actually get the data. It's not that easy. Because documentation is just not very well done. And it's because of stressful situation. And too many people. So it's huge variation.
The number of data which we need to enter is also too many for a patient.
Yes.
How do you activate the team members? Call center person should call individually, like one by one and do it, or how do you do it in your place?
Yes, so fantastic. So what we do is that there's a roster. So originally we used to use this thing called Tiger Connect, right? So Tiger Connect was very nice because people don't call the doctor. They don't call Dr. Kamlesh to, oh, shock team. They call a role. So if you have a role as a shock consultant, right, they just call the role and everybody gets activated. But then we move towards teams. So then call center becomes useful because what happens is they send a text just like cath activation text. If you text one, that means it will say shock team has been activated. 0. If you acknowledge, press 1. Send 1. So you will send 1. The call center person doesn't need to call you. But if you don't acknowledge within 2 minutes, the call center person will call the person who has not acknowledged. This is a good way of activating groups. Sometimes what in the initial part when we started is actually literally everybody gets called. So it gets a bit challenging. So, but the good thing is our team is quite tight. And it's the same guys all the time. So I'm on call 365 days. And I have a backup person also. So we have 2 of us take turns to be the lead. So what happens is that it's very, very tough. But the reason why we did it is because we truly believe in it. And we believe that if we have consistent team, then what happens is that the outcomes get better. And then after that, we can start teaching people and more people come in and we can create a proper roster. But in the initial part, it was very challenging. It's just a very core group, right? You don't need to remember the roster. It's only the same 5 people, right? And then thereafter, then we increase the number of folks. And we had champions in peripheral centers and all that. But the activation, it is very cumbersome if there's 5 people and you have to call 5 people. And what if some guy doesn't pick up? It's also challenging.
What do you think the role of emergency room physician, like when someone comes with low blood pressure, what looks like myocardial infarction with a blood pressure of 90 systolic, by the time the shock team gets activated, what all he is expected to do it? Like, do you think that, he should put an arterial line, he should put a PA catheter at the bedside? Do you think that, vasopressors should be started immediately? What's your choice of vasopressors? Yeah. At what level, you think that vasopressors have reached the maximum? These are the basic things, which we encounter day by day, day to day.
Honestly, I will say the less is more. So we don't expect them to put an arterial line. We don't expect them to put even a central line. They are extremely good at getting cannulas in. They get a large bore, 16 or 18 gauge cannula. They can start peripheral norepinephrine. Right, the registrar will then do the activation, so they do the resuscitation part, right? And then if norepinephrine is not sufficient and they are starting a second agent, ECMO team is already on the way, right? Even if they are not needed, it's fine because they will then follow the patient to the cath lab. So we do not make them do a lot of things. Because the moment you make them do a lot of things and they have 2 or 3 competing patients at the same time, it is very difficult for them. It's not possible. Even we can't do it. So we have to be fair to them. I think in the end, the most important thing for them is that they do a bedside echo just to see the EF, roughly. They need to sky stage, they need to communicate it to the registrar. They need to load the patient with DAPT. They need to set the relevant bloods, including the venous lactate. And if need be, intubate the patient. That's it. Yeah, now intubation, you think, because intubation is another thing that some folks ask me. So when should you intubate? It's a very controversial question when you answer, because any physician will say, hey, look, the patient is very unstable. You want me to intubate the patient? Are you sure? So the whole reason why we have the shock team also is because we want to support that person. Because you don't want a situation where the guy intubates, the patient collapses and say, why are you intubating? It's not fair. Right? So we actually support the A&E physician's decision to intubate. Now you ask me, why do you want to intubate? Because, and correct me if I'm wrong, interventionists, when a patient is on table and they start to go APO, it is the most frustrating thing. Because you are scrubbed up, you're holding the catheter, and this guy is trying to sit up because he's drowning in his own fluid, and someone is doing violence to the fella, right? It's trying to give some sedation and trying to put a breathing tube down. It is really a disaster. And that's when collapses happen, that's when complications happen. So we want to avoid this, right? So if the patient is in profound shock, we actually intubate them early. And we have a plan of how we intubate them. For example, acidotic patient, how do you intubate? Honestly, anesthetists are brilliant at this. So most of the things that I learned and I follow, A&E person, especially from anesthetists, they're very, very good. You have a plan A, B, C, D, E, F, G. And we intubate early. And once you intubate, you drop the VO2 requirement of the patient and you realize that the patient actually stabilizes. So that's important. And they use ketamine, for example, instead of giving high doses of propofol. So all these things are actually discussed. We don't actually mention in the protocol, you realize, right? But it's actually discussed. We tell them, look, part of the workflow, the policy is that you have to use lower dose of drug because the EF is low, use things like cardiostable drugs, intubate early rather than waiting until the patient is really going to crash. So these are things that we actually discuss, and we do it as a team. So that if the patient arrests, too bad. But at least it is not too much pressure on one person.
A couple of questions. The first question is like, no, for a cardiac arrest, we have something called code blue. For shock, anything like any coding is there? For cardiac arrest, for cardiac arrest, we call it as a code blue. For shock, is there any specific terminology has come for that? Any coding is there?
So we just call it shock, cardiogenic shock activation. So if you saw the protocol, it says Singhal's cardiogenic shock. Singhal, because it's our cluster, so it's about 3 hospitals, and we all speak the same language. Yeah, so we don't call it code blue, but we call it cardiogenic shock activation. Yeah.
Any protocol is there, like no, you incorporate artificial intelligence in your like combating team, anything like that?
Artificial intelligence?
In order to prevent, yes, in order to prevent human errors. Is there anything like no, you apply something from artificial intelligence and do about anything?
Yeah, so that's a very interesting question. So I work in the telemetry work group as well. So we are looking at artificial intelligence to assess for patients in cardiogenic shock. So I give you an example of it. Looking at, so one of the beautiful things that if you can do and achieve is looking at ventricular arterial coupling to decide whether to give vasopressor, to give fluids and all that kind of thing. So the truth of the matter is very cumbersome, very difficult to do. What we have at the best is pulse contour analysis, right, and most of those things. So we are trying to see whether we can integrate other parameters, but it's very much in infancy. So it's part of the discussion, but actually there's nothing actionable that we have done so far in terms of artificial intelligence. But I do believe that that is going to be the future. So I do have one more slide to show you. This one, I just got it out last week. It's basically, we changed a lot of workflow, right? So I'm a big believer in not doing too many procedures or too many cumbersome, complicated, expensive things. I truly believe the simpler you make your protocol, the easier it is. And when it's easier and people can manage it and can do it consistently, people get better, and you realize outcomes get better. So if you look at this table, it's basically showing a few things. Number one, it's showing the number of patients that get admitted to our ICU as an ICU patient. Let me see, ventilator, certain degree of norepinephrine, CRT, and so on. We have roughly about 600 patients. So when we came up with all these workflows, whether it's TTM policy, whether it's, all these things are free. There's no cost with them. We dropped the admission rate itself down by 7%. Right? So patients who shouldn't be in the ICU, patients who, like for example, earlier question, should we even do ECMO for these patients? These decisions are made with multiple people, is much easier. One guy making the decision, especially when he's not there, is terrible. You will always err on the side of putting the ECMO, right? Because you don't want to have it on your conscience that the patient died. But when you have a group of people discussing the case in a very organized fashion, consistently, multiple times they have experienced this, is much easier. So 7% reduction. But that's not a thing. We overflow to other ICUs, so we are not combined ICU like yourself. We have multiple different ICUs. And our overflow rate also fall by 72%. But what is more important is the ICU length of stay, which is what was my goal. That reduced quite dramatically. And there is no, we didn't include any other fancy toys or any fancy devices. So I do hope that, for your own centers, think about what you can do at the bedside, what you can do, simplify things, how you can maybe protocolize things that, are good practices, and I can tell you that will make a huge difference to bed numbers. So I think that is what I really hope people take away from this. Any other questions?
How many of the patients reaching your place are medically insured? All of them are...
Okay. So medical insurance in Singapore, there is private insurance, of course, that people have, and it's tiered. So for example, if you go to a private hospital, then what happens is that your insurance will cover a certain amount, depending on how expensive your insurance is. But my center, public center, so public hospital has tiers as well. There's A-class patients, right? They have single room, and all that sort of thing, but they don't actually have any difference in care when it comes to the ICU. ICU, we treat everybody the same. So there's no difference. Now, the insurance for A-class will cover almost always everything. But if a person is not insured, not a big deal, because there are social systems that protect them. So they will be C-class, we call it C-class patients. C-class patients, basically, there are 2 tiers. So there's co-payment, that means you pay a small amount, the rest of it is covered by the healthcare system. If the patient really has no earnings at all, then there's this thing called Medifund that's there that actually pays for the entire healthcare bill. So in Singapore, we don't have a state where everything is covered. It is, you can have your own private insurance, or there's a government-based insurance. So, but the truth of the matter is this. So if you take Impeller, so the Impeller company came to us, and you go to every cardiology talk, they talk about Impeller as the big thing. The problem is that it is not subsidized, right? And if it's not subsidized, then what happens is that it comes down out of your bottom dollar, because government said, look, I'm not going to use public funds to do protected PCI for your Impeller. So insurance are the same. They say they will not pay for it. So in the end of the day, it comes from the bottom dollar of the hospital.
Dr. Rajesh, you can invite our department colleagues to share their ideas. Dr. Kamalesh, you can sit there.
Thank you, sir. Clear structure, clear activation pathway, and clear accountability. I invite core group members to provide their inputs. To summarize this important discussion and announcing our shock team, I invite Dr. Veena ma'am.
So thank you, Dr. Kamlesh, once again. So what we have discussed today makes it clear that shock management is not an individual decision. It is a system decision. It's a team decision. So we are in the process of building a shock team. And what is primary, I felt, for that standardizing the shock team, first step is we have to standardize recognition. How do we standardize the recognition at the time of arrival of the patient, whether we can define physiological trends. Everything is bedside. It's not fancy monitors or fancy tests which we require. It's only physiological triggers which we need to identify and which we need to standardize. Everyone should be able to pick up these core signs when they are coming to the ER. I think that is the primary standardization which we need to work on. Second thing is how do we initiate this? Who calls whom? After calling, what does the second person does? And how does the whole core team come to assimilation, and how is it going to translate into managing this patient? It's not only calling the patient and and how is it going to translate the patient, and whether this call is attended at the same intensity 24/7. So that is also, I think, one of the things which maybe we'll have to work out, because in the best part of the day, most of the senior consultants and the shock team, ECMO team, cardiac anesthesiologists, surgeons, all of us are available. Not that we are not available, but how soon can we come to the center? So that is the thing which we need to establish second. And lastly, what I was, this one is, last but not the least is we have to build a team. We have to build a responsible care team. which comprises of emergency physicians, which comprises of intensivists, cardiac surgeons, cardiac anesthesiologist, intervention cardiologist, our allied specialties which are the most important, nurses, physician assistants, ER physicians and ER nurses. And this should not function as an hierarchy. It should not be that the cardiologist, cardiac surgeons, intensivists, it's not a hierarchy system. It's a shared responsibility. Only then we can implement a shock team and we can implement success in the shock team and we can start the program. Thank you. Thank you, doctor.
Thank you, ma'am. That is how system saves lives. I now invite Dr. P. Vinod Kumar sir, our interventional cardiologist, to give an overview concept on cardiac dysfunction clinic and rehabilitation center.
Good afternoon. Dr. Kamlesh, that was a fantastic talk. We will probably interact more when we have the scientific meeting. So about the cardiac dysfunction clinic, we all know that heart failure clinic exists throughout the world. Why use the term cardiac dysfunction clinic? Because first of all, this terminology is coming into use more and more in the research articles as well as in many of the premier institutions. This terminology is being used. So, and also that to avoid any negative connotation to the patient which they may have with heart failure, so cardiac dysfunction seems to be an appropriate term. So what it exactly means is that cardiac dysfunction clinic will be a multidisciplinary structured clinic where all groups of heart failure, dysfunction, be it the heart failure with reduced ejection fraction, mid-range or preserved, RV or LV, all the dysfunctions will be encompassed to the clinic. And why this cardiac dysfunction clinic is important is because many of the guidelines as well as research articles have shown that this usage of the heart failure clinic increases the guideline-based medical therapy coherence or usage, as well as it reduces the hospitalization, it improves the cardiovascular mortality clearly. And what is the core team consist of? It is a heart failure cardiologist, and you have a heart failure nurse, you have a dietitian, and you have a device specialist, and of course you have the cardiac surgeon as well as the advanced heart failure team and transplant team. So the clinical workflow generally how it works is that the cardiac dysfunction clinic will be optimizing the guideline directed medical therapy and adjusting the volume status of the patient, optimizing the volume status of the patient, and also looking into the biomarkers and the labs periodically and modifying the risk factors and comorbidities like anemia. Everything will be corrected appropriately. And the most important thing will be, again, the device management like CRT requirement, if the patient requires ICD or any arrhythmias, then EP specialists will also be coming into the picture. And cardiopulmonary exercise testing, which will be a very important component of the cardiac dysfunction clinic, where you decide the patient which is going to be listing to a transplant or a LVAD, or you can, again, if the patient improves, you can delist from a LVAD or a transplant. So that is the very important thing. The other thing is a cardiac rehabilitation program. This cardiac rehabilitation program is a distinct but very closely related to the cardiac dysfunction clinic. We all know that in patients with cardiac dysfunction heart failure, exercise improves the overall quality of life, as well as it reduces hospitalizations, it reduces CV mortality. It has been shown with trials like HF Action and meta-analysis have clearly shown that. So the cardiac rehabilitation team, again, the core team will consist of the cardiologist, mostly heart, the same as the cardiac dysfunction clinic. You will have a most important person will be a physiotherapist or a exercise physiologist or a counselor to tackle with the vocational counseling or occupational counseling, and also a psychologist to assess the stress and other factors. So who will come into this picture? If any person who is stable enough, like a patient comes to the cardiac dysfunction clinic, gets optimized, and they get referred to the cardiac rehabilitation center for exercise therapy. So, here they will be concentrating on the exercise training, risk factor modification, and so forth. So both the things are very important. So we can think of the cardiac dysfunction clinic like engine tuning, and cardiac rehabilitation program like the refining the performance of the patient. So thank you.
Thank you, Doctor. I now invite our senior cardiothoracic surgeon, Dr. Mohan, to speak about Billroth transplant program.
Good evening, everybody. Thank you, Dr. Kamlesh, for coming over, and really an excellent speech. And that's exactly the direction which we are thinking of at the moment to start up in Billroth ECPR program, an ECMO program. So we need to work on the flow chart as you have done, and that gives us some insight how we have to go about. And I took over the Department of Cardiothoracic Surgery here in May, and when we came with the insight of we have to go start the transplant program and heart failure work as well. And Dr. Veena and I, with Dr. Vignesh, we were part of the bigger team here under Dr. K.R. Balakrishnan. And so we moved out and we started independently. So we had our 3 patients registered, in which one patient died before we could even establish our program here, and Dr. Veena had not joined by then. So after she joined, we had our first transplant done on September 9th, which is that girl sitting out there, and she has a patient with dilated cardiomyopathy getting sicker, and we got a good donor nearby, and she just breezed through the ICU. She was out of the ICU in 10 days and discharged on 16th, 17th day, and she's still doing well. So we have now started off the heart failure program at our institute, and we are slowly getting more and more patients registered under our care for transplant. So we are here with a team of 4 anesthetists, 3 surgeons, and a good team of intensive care nurses, perfusionists, all working round the clock, 24/7. And also, parallelly, we have developed our ECMO program as well. We did 3 ECMOs with good success in the 6-7 months which we have been here. So we are slowly looking at more and more registrations to our transplant program. And with the big team of cardiologists here, I'm sure we'll be doing much more. So thank you very much. Thanks for the support, and thank you once again.
Thank you, Dr. Mohan. I invite senior cardiothoracic surgeon, Dr. Bharat Guru, to add few points on structure follow-up of transplant recipients.
Good evening, everyone. It's a pleasure to address this august gathering. I thank our chief guest also for his insights into how we should be developing our shock program. And so as we know, we are here because we have done a successful heart transplant, and we are looking forward to doing many more in the future. With regards to heart transplant, the surgery, and it doesn't end with the transplant being done. Most often these patients, they have to be instructed that it is a continuum. Whatever we have done doesn't end with the surgical procedure alone. Most of these patients require intensive follow-up throughout their life. And as you would say, it could be divided into three main pillars. One is where the patient needs to continue with their medicines, their anti-rejection medicines, which they will need to take for their lifetime. And the heart also needs intense monitoring. We'll have to keep monitoring the patient for the any chances of rejection. And more so, the patient also needs to identify, and they have to know that there are certain restrictions which they will have to follow through their life, which we call as an isolation bubble, where they cannot be free to, any sort of infection will lead to a poor outcome later on. So it has as much role for the doctor as well as to the family in order to take care of these patients in the post-operative phase. So we make sure that we educate the patient that all this is being followed, so that whatever gift of life has been offered to the patient, they should benefit from it for a very long period of time. And yes, this is something which we should, our work does not end with performing the surgery alone. Our work also extends to teaching the patient to maintain a healthy lifestyle in the future. Thank you, sir. Thank you.
Thank you, Dr. Bharat Guru. Pulmonary embolism can deteriorate in minutes. It demands coordination across emergency cardiologist, CT surgeon, imaging, critical care. I invite our senior consultant, interventional cardiologist, director of electrophysiology, Dr. Ilayaraja, to introduce the concepts of pulmonary embolism rapid response team.
Good evening all. Welcome, sir. At the outset, I would like to thank our beloved chairman, for being with us and for having this wonderful CME, especially, in this ambient atmosphere. I hope you agree with me that, the great food served and the visiting faculty and the visiting, guests, they would agree with me that the Billroth hospitality is one of the best. So we discussed in detail about the cardiogenic shock. Now let us move on to how to address pulmonary embolism. This is a teamwork. Even for this conference, a lot of teamwork, they put into, say, critical care headed by Dr. Chakravarti, 24/7 dynamic personality. And then we had entire support from cardiothoracic surgeon, that is headed by Dr. Mohan and Dr. Bharat. And we have our cardiology team with two wonderful mentors, a senior consultant with us, Dr. Professor B. Ramamurthy and then Dr. Shanmugh Sundaram. And we have a good ally with us, Dr. Vinod and Dr. Samuel. And now I think we geared up after this introduction of post-graduation in our institute, so Dr. Angush with us. So that serves the concept of 24/7. Now, when we look at the pulmonary embolism, it is not that easy to pick up the diagnosis first. So diagnostic challenges comes first, and then of course treatment challenges. When someone presents with breathlessness to ER, it could be still anemia, hemoglobin 4 grams. Till you receive this hematology, you think of so many things, and then finally when we look at a hematological report, it says just 4 grams. The patient needs only evaluation for anemia and then correct it as quickly as possible. On the other hand, non-COPD patients every time presents with acute exacerbation, and then unless you dig into their history, you really get confused when they present with respiratory failure. So let it be acute coronary syndrome or pulmonary embolism, all you offer differential diagnosis that indicates a quick response and then a clear protocol at the ER level will solve this problem. When it comes to treatment challenges, if the patient is hemodynamically unstable, that's what we discussed in the first lecture, beautifully by Dr. Kamlesh. And then, when the blood pressure 80-60, we have no time to, or we have less time to respond. Office hours, everybody available. Whereas, what happens if a patient comes in the night hours? Not only this pulmonary embolism cases, in many of the major centers, even ACS results, especially when they looked at literature, morning hours versus night hours, the night hours results are not that great. So we should understand and we should really take the result with a pinch of salt. Meaning, unless you have a clear teamwork, and that is well linked, then this could be addressed or the eventuality can be minimized. With this idea, with the particular reference to this pulmonary embolism, when the case is diagnosed, then we have the following options. If the candidate is actually no contraindication for clot buster, that can be used. And when there is a contraindication, now I expect that all this information will be shared by Dr. Kamlesh. There we can take the help of even interventions. So in our center, we have been doing all sort of the maneuvers. So for example, let it be clot buster, or if the patient requires interventional procedures, that also we are doing with the help of a penumbra system, that is 8 French. Of course, it has its own limitations, especially when somebody is having soft clot, recent onset, when it is sitting in the proximal trunk, so you can reach out and then you can do some kind of a salvage process there. Of course, Inari is in, and then we expect you to deliver more. So thank you for your valuable patience and attention.
Thank you, sir. Now I invite consultant pulmonologist Dr. Amal Johnson, Billroth Hospital, to speak about pulmonary hypertension clinic, the need of our hour.
Good evening, everyone. Good evening, sir. Sincere thanks for this opportunity to speak on pulmonary hypertension specialty clinic, the need of the hour. Just a second. I have a small presentation, unlike other senior cardiologists. My presentation? Good. Oh, thank you, sir. So I can just. Can everyone see it? Yes. Thanks. So, pulmonary hypertension is basically an increased pressure in the pulmonary arteries. It increases a strain on the right side of the heart, causing breathlessness. Untreated pulmonary hypertension can lead to right heart failure and mortality. Pulmonary hypertension is not only one disease, but it's a syndrome with multiple causes. This is just a small introduction towards what is pulmonary hypertension. And pulmonary hypertension is often missed because most patients are mismanaged as asthma or chronic obstructive pulmonary disease. PH is not completely rare, but it is rather underdiagnosed and undermanaged. So there is a definite lack of awareness which contributes to a late stage presentation and a delayed diagnosis worsens long-term prognosis in these patients. So there is an increasing burden and pressure now because of the increasing population in terms of age, increasing heart failure cases, chronic lung diseases, connective tissue disease, post-COVID vascular damage, chronic pulmonary embolism. So if you take in our country, the awareness is up and increasing, but we need more structured pulmonary hypertension programs. That is why a dedicated model becomes essential here. So pulmonary hypertension has 5 major classification groups, and if you take one group, it will require a distinct management approach. So classifying this patient incorrectly may cause therapeutic harm, and PAH specific drugs are not suitable for all patients. So accurate management is very important before picking up these patients and classifying them accordingly. So the must not miss condition in this regard will be chronic thromboembolism induced pulmonary hypertension. It is potentially completely manageable, curable. So persistent breathing difficulty after a pulmonary embolism, we will need some evaluation and complete management in terms of surgical endarterectomy will be therapeutic for this patient. So in a pulmonary hypertension specialty clinic, we will have, instead of scattered evaluation, standardized screening, structured workup, proper classification, proper evidence-based management and monitoring these patients. So pulmonary hypertension will not be a single multi-specialist approach will be there, consisting of cardiologists, pulmonologists, rheumatologists, intervention specialists, and heart-lung transplant team as well. So conclusion would be a pulmonary hypertension is a very important progressive condition, serious condition, but manageable very much when picked up early, and we have to have a proper established pulmonary hypertension specialty clinic in this regard. Thank you.
Thank you, Doctor. I invite our cardiologist, Dr. Ramesh sir, to announce the Billroth PERT team and PAH clinic team members.
Good afternoon. Thanks for the opportunity. I thank our entire cardiac and thoracic team for wonderful work we are doing through the pulmonary embolism and PAH work. And as we think the pulmonary embolism on PAH, it is not just cardiology and pulmonology work. It has an entire set of team members which involves total of 10 members. As like shock team, we need to have an entire team for it is more of a patient-centered treatment. Where in case of pulmonary embolism, the initial starting is emergency department, where they need to work up for the etiology, and the second department will be internal medicine to identify the provoking factor and thrombophilia screening and cancer evaluation. The third will be the radiology for CT pulmonary angio, Doppler and echo. And fourth will be the intensive care for ventilatory support, mechanical circulatory support, ECMO and vasopressors. And fifth will be the interventional cardiology for a catheter-based direct thrombolysis. And in case where thrombolysis is contraindicated, surgical team is involved. And at last will be there will be a regular follow-up. We need the total 9-member team for the pulmonary embolism response team to be activated. Whereas in pulmonary artery hypertension, it is a chronic disease and it is progressive and is a complex disease. It not only affects the pulmonary vasculature, it affects the right heart functional capacity, nutrition, psychology, and overall the quality of the life. And here the first will be cardiologist and pulmonologist for risk diagnosing and risk stratification and initiation of the advanced therapies. And next will be the physiotherapy for improving exercise tolerance and muscle strengthening, radiology for cardiac MRI and to assess the disease progression, and transplant team to assess suitability for the heart and lung transplant, and clinical advisors in case of any upcoming novel drugs, whether we can introduce for the pulmonary hypertension patient, and a specialty pharmacist to titrate the pH-specific therapies and to assess drug interaction and improve adherence to the patient, and nutritionist for a salt balance, and most important thing is nurse specialist for a patient education and monitoring symptoms. They usually handle the infusion therapy. And last but not the least is the social worker to assess, to discuss with the family members regarding the financial issues and lifestyle modification, and there should be a complete one-to-one family counseling for the entire team. Thank you.
Thank you, sir. Structured effort, defined escalation, clear ownership. That is how mortality reduces. Cardiac arrest is unforgiving, but modern medicine gives us one more opportunity if we are prepared. I invite our lead consultant of critical care unit, Dr. Chakravarti, to discuss the practical aspects of eCPR.
At the outset, I think we have moved now from the CPR, regular code blue cardiopulmonary resuscitation, for any cardiac patient to the eCPR, that is ECMO-assisted cardiopulmonary resuscitation. This is usually when to screen what patients we have should I initiate on eCPR. The age criteria will be 18 to 65. If at all 62 to 75, the clinician discretion how patient is fit. And the reversible causes always keep in mind before initiating ECMO, that is acute coronary syndrome, arrhythmias, underlying pulmonary embolism, or hypothermia, toxicity because of any drug intoxication, and myocarditis. These are the reversible causes, so definitely the patient will get benefit. And excluding patients will be usually advanced malignancy, terminally ill patients, patients who have massive intracerebral hemorrhage, end-stage diseases, and end-stage organ failure, or severe frail patients are not so indicated for eCPR. If at all your patient is fit for it, then definitely you have to go for cannulation. So eCPR activation algorithm always in patients with witnessed cardiac arrest, that immediate CPR was initiated to the patient, and definitely worth trying eCPR. So shockable rhythm are presumed to be reversible cause, definitely an indication for eCPR. And no flow for less than 5 minutes or low flow for less than 60 minutes, definitely you can consider for initiation of ECMO. No ROSC after 10 to 15 minutes of regular CPR, I think you can go for definitely after ACLS, after 10 to 15 minutes of CPR, I think you can go for ECMO activation. Always in our calls and in our hospital, we used to keep 1305 as a landline extension and the mobile number given for activation of the eCPR in the hospital throughout. These are the members of our code eCPR, the ER consultant, CCU consultant, primary consultant of the patient, cardiothoracic surgeon, cardiac anesthetist, perfusionist, senior cath lab technician, ER and ICU in charges, and also manager on duty for taking care of logistics. I think these are the members of our eCPR team. I think we have to go and add on value to the lives with initiation of more and more protocolized version. Thank you. Thanks for the opportunity.
Thank you, Dr. Chakravarti. To deliver vote of thanks, I invite Dr. Preeti to address the gathering. Good evening all. It's my privilege to propose the vote of thanks for today's enriching and forward-thinking session. At the very outset, I offer our deepest respect and heartfelt gratitude to our esteemed chairman, Dr. Rajesh Jagannathan sir, whose visionary leadership continues to steer our institution towards clinical distinction and innovation. We are equally grateful to our respected managing director, Dr. Kalpana, and our CEO, Mrs. Satya, whose administrative strength and strategic guidance enables the seamless translation of vision to this action. I also extend my sincere thanks to our respected chairpersons, Dr. B. Ramamurthy, Dr. Chakravarti, and Dr. Veena for their continued guidance in nurturing academic culture within our institution. A special note of appreciation to Dr. Shanmugasundaram for initiating this important discussion and setting the stage for purposeful exchange. I would like to place on record a deep appreciation for Dr. Kamlesh for his outstanding address, his lucid articulations on the importance and formulation of the shock team, his candid insights into the real-world challenges, and his sharing of structured, experience-backed protocols have provided us just not inspiration, but a practical roadmap for implementation. His presentation truly set the tone and direction for today's informative initiatives. I collectively thank all our esteemed speakers for their valuable contributions. They represent a decisive step towards structured, protocol-driven, multidisciplinary excellence. Today's session is not merely an academic session. It marks a strategic advancement in strengthening system and elevating patient care standards. Finally, my sincere thanks to the organizing team and everyone behind the scenes for ensuring the seamless conduct of this program. Let us carry forward today's momentum and translate these discussions into a memorable clinical impact. Thank you.
Thank you, one and all. I think now this afternoon session of scientific session is over. Next stage is set for the press meet. Followed by that, we can again evening CME will commence. Thank you all for your attention and joining with us today.